Welcome to our oxygen delivery lesson. You can find this on pages 124 and 125 of your Nurse Workbook 2.0, or you can print the pages below this video so you can fill it out with me or always come back and test your knowledge. The purpose of this video is intended to give you real-world nursing education beyond just the Nurse Workbook itself. And in our previous video, we talked about the 5 terms to have effective lung compliance and efficient oxygenation. And in this lesson, we're gonna get super basic and we're gonna learn about our airway equipment. And once we understand our equipment and we know these 5 terms that we just previously learned about, we're gonna know what equipment we need for our specific patient situation. So we're gonna review 2 terms before we get started. Our FiO2 is that fraction of inspired oxygen. And what this means is it's how much oxygen concentration we're gonna be putting into our patient. So room air is 21%, but we can also put up to 100% of that pure oxygen in our patient as well. And our flow rate is that liters per minute. So if someone is getting 2 liters, they're getting 2 liters per minute. So now that we know those 2 terms, we're gonna start with our nasal cannula. And this is used for our patients that require a low to moderate increase in oxygenation concentration. So we can give 1 to 6 liters per minute in our adult patients. And essentially, this equals 24 to 44% FiO2. So this nasal cannula is pretty ideal for our patients that can breathe on their own and they have no real need for any kind of higher intervention. Nasal cannulas make patients allowed to be pretty mobile, and we can also have our respiratory therapist set patients up with oxygen for when they go home. So even if they have a temporary illness and they need a little bit of oxygen, we can always get them a tank and they're able to utilize this at their home. Additionally, if we give a pain medication that can temporarily repress that respiratory drive, we can just throw a little bit of liters on them and watch their oxygen bump right back up. But in our pediatric patients, we're going to need a smaller nasal cannula because not only are their little noses much littler than ours, but we're also gonna dial back that flow, how many liters we're gonna be putting in. So our pediatric patients, we're gonna put in 1 to 3 liters per minute through their pediatric nasal cannula. And in our infants, we can actually give 0.01 liters up to 0.25 liters per minute. And as you can imagine, these cannulas are so tiny and need little stickers to keep them in place. Most of our babies don't like it, but eventually they'll forget that it's even there. And usually this makes them sleep a lot better because this sickness requires this oxygen and they can finally get some rest. And we want to remember that no matter what we're doing, we want to always strive for 92 to 98% of our SpO2 or pulse oximetry reading. Next, we have our non-rebreather mask. So this is going to be utilized for patients that need a higher concentration of oxygen. This is going to deliver an FiO2 of 60 to 100%. And this will be a flow rate of 10 to 15 liters per minute. So this non-rebreather mask is made with a reservoir bag. And we can see this bag right here. There's also a one-way valve that prevents exhaled air from re-entering this bag. And this allows our patients to breathe almost 100% pure oxygen and not their own carbon dioxide. So this non-rebreather mask is going to be super ideal for patients that have maybe carbon monoxide poisoning, or they just over a short period of time need a big blast of oxygen to pull them up out of the moment. And this mask has the ability to open the vents so we can always allow that room air to come in. For our pediatric patients, we can also give them 5 to 15 milliliters of this non-rebreather also. But the most important takeaway from these non-rebreather masks is that reservoir bag. If this bag is not inflated, then this is not functioning properly. And this means that our patient will actually be sucking in their own carbon dioxide. So if you see any fogging inside that mask or this bag that isn't blown up, then this means this bag is not effective and this can actually do more harm than good. We can also do a partial rebreather mask, and this is similar to the non-rebreather, but it allows for the mixing of our exhaled air or carbon dioxide with 100% oxygen. So we can deliver an FiO2 of approximately 40 to 70% at 5 to 7 liters per minute on our adults. This partial rebreather mask is fitted with the Reservoir Bag also, but it lacks that one-way valve and allows a patient to re-inhale some of the exhaled gases. And this is going to be suitable for our patients that need a little more than what a simple mask is, but they don't really need a non-rebreather. Even though we can definitely hit 10 liters in this partial rebreather mask, it's something to consider, or a red flag to go off in your head, that if you're needing 10 liters on a partial mask, you should probably be switching up to a non-rebreather. And that simple mask is a mask that's going to be used for patients who require a moderate increase in their oxygen concentration. So this can provide an FiO2 level of 35 to 50% at a flow rate of 5 to 10 liters per minute. So these simple masks are going to be more comfortable for our patients, and they're also going to be a lot less claustrophobic. So this can be better for somebody that needs a little bit above a nasal cannula, but they don't necessarily need that non-rebreather. There's also something to talk about when it comes to simple masks, and that is providing that blow-by. And blow-by is not something that is allowed by most hospital facilities. So I think it's important to talk about. So in our pediatric world, when we go to put a nasal cannula or a mask on our kiddos, typically these kiddos are going to freak out and try to take all this stuff off of them. The other factor is these kids are sick. There's a lot of stranger danger going on. And so they are just genuinely upset. But they're sick, and respiratory in our pediatric world is a really big deal. So is getting some oxygen better than absolutely no oxygen when this pediatric kid is crying and destatting? Absolutely. We can always blow that oxygen into their face. We do this with nebulizer treatments as well. So blow-by can be efficient to just kind of help them through this moment where they're panicking and they're freaking out. And then we can also call RT and kind of tag team up and see what kind of interventions we can do to avoid having this blow-by being necessary. The thing that blow-by is absolutely not is a simple mask tied, or any kind of mask, tied to the side of the patient's bed rail while the patient's sleeping and walking out of the room. So this could be a temporary fix for when you want to go get some help, and that way you can figure out a better solution that you can measure the amount of oxygen that this kid is getting. And the whole thing about blow-by is we cannot measure how much this kid needs. So how do we know what kind of direction this kid is going if we can't actually measure it? So don't do that. And when these 4 type of masks aren't going to cut it, we can move on to more of a non-invasive ventilation, but definitely a step up from these masks, but below our invasive intubation. Our first kind is our continuous positive airway pressure, or our CPAP. So this delivers a constant, steady stream of air pressure to help keep our airways open. The beautiful thing about CPAP is that our patients are able to take this home and utilize this at home. And typically this is used for something like our sleep apnea. It can also be used in our heart failure, or when a patient is just having that moment of deoxygenation and needs a little bit of help. So with our CPAP, the patient determines the respiratory rate and the volume of air. And they really select this by how they're feeling. Our normal range is going to be 5 to 10 centimeters of water pressure to keep those airways open while they're using a CPAP machine. And our bi-level positive airway pressure, or our BiPAP, provides 2 levels of air pressure for our inspiration and our expiration. So this is going to provide tidal volume, and it may or may not provide a respiratory rate. So when we talk about 2 pressure levels on our BiPAP, what this means is we're actually pushing in first our pressure in the inhalation, and we're going to push that pressure in. But when the patient is exhaling, there's a low pressure that's also going to be going in as well. And what that's doing is it's keeping that alveoli open. So if we remember back from our PEEP, our positive and expiratory pressure, this is going to help keep the alveoli open at the end of expiration. So our BiPAP is able to do this without going through our invasive intubation. But the most important thing to remember about our BiPAP and some of our CPAPs is if your CPAP has a mask that looks like the BiPAP will always have a mask, there is a very tight seal that goes around the nose and into the mouth. And this also wraps around the head to make sure this stays tightly in place, because we want to make sure that we're making this efficient lung compliance and adequate oxygenation exchange going on. So if our patients are unable to take this mask off themselves, then they should not be on BiPAP or CPAP. And the reason for this is when we're pushing pressure down into the lungs, and if this patient happens to get sick, they can always vomit and they can aspirate. Not only will they aspirate pneumonia into their own lungs, but they'll be also sitting in a vomit-filled mask as well. And although that's easy to pop off the mask, our patients don't always know this unless they've been on BiPAP multiple times. So if they do not have the strength to remove this mask, they absolutely should not be on it. In addition to our drunk patients or our altered patients that don't understand why they need this mask, you cannot restrain patients either because they won't be able to take this mask off. And I've seen this been done before, and I've gone in and taken these restraints off. So a wise person once said to me, if a patient cannot sit up and eat a cheeseburger, then this patient cannot go on a BiPAP or a CPAP with the mask as well. And our normal range of a BiPAP is this inspiratory pressure of 10 to 18 and that expiratory pressure of 5 to 10 because that's our lower pressure. So we're going to go back to that little paragraph before we got into our CPAP and our BiPAP. So our non-invasive positive pressure ventilation requires the patient to be able to protect their own airway. Aspiration risk is too dangerous if a patient cannot take the mask off in case of emergency. And if all of these methods fail and none of the following airways are supportive enough for our patients, then we're going to provide this very invasive ventilation known as our intubation. And intubation is when we place a tube through the mouth or the nose or the trachea to secure an airway for patients that cannot protect their own airway or they're unable to maintain an adequate gas exchange. And we don't just do this for our patients that are critically sick. We'll also do this for our patients that need surgery and are going under general anesthesia. We can do this in facial traumas or even burns in the airway where we're worried that the swelling is going to become too great that they're not going to eventually be able to protect their own airway either. So this also includes various airways beyond just our endotracheal tube. We can have our laryngeal mask airways, our tracheostomies, and once this airway is established, a ventilator is going to provide the tidal volume, the FiO2, the respiratory rate, the airway pressures that we talked about under adjustable settings depending on the patient's needs. And because this endotracheal tube or these airways are going to be passing through our throat, it's important to remember, not just for us that are learning, but for our patient education as well, that the reason we never give people food or drink when we think there's any indication they could be going under sedation or possibly get one of these tubes, so in our emergency departments or before surgery, is that no matter who you are, if you are conscious or if you are even sedated and they go to put this tube in and you still have a present reflex of any sort and you're not paralyzed, then the gag reflex happens. And the gag reflex is what can stimulate gastric contents coming up and aspirating into our lungs. If this happens, this buys us a 2-week window of pneumonia, which we're probably going to stay in the hospital longer. So we don't withhold food or drink to torture our patients. We do this because we're so afraid of that aspiration risk from this intubation or endotracheal tubes. And before we go, we're going to do a quick little bonus and go over 6 additional airway tools that we use, and these are not found in your workbook. First, we have our oropharyngeal airway. So these are curved plastic or rubber tubes that are inserted into the mouth and they keep the tongue from blocking the airway. We also have our nebulizers, and these are going to be used to administer medications in the form of mist that's going to be inhaled into the lungs. We have our nasopharyngeal airway, and this is a nasal trumpet. This is going to be a soft, flexible tube that's inserted into the nostril to keep the airway open. And this is not going to be for our conscious patients because this tube is going to stimulate that gag reflex. So when a patient becomes conscious, which we can utilize this a lot in people that are drunk, then once they come to, they're going to start to gag, and we want to pull that tube out. The great thing about the nasopharyngeal and the oropharyngeal airways is that we can put a mask or a nasal cannula even up to these and still administer oxygen through it. We also have our BVM, this bag valve mask. So this is what we use in emergent situations when we need to manually ventilate a patient during resuscitation or other emergencies. And this consists of this anesthetic mask and an ambu bag. This laryngoscope is going to be what our providers use to view the back of the throat for checking for intubation and any abnormalities of the larynx or the vocal cords. Sizing of this blade is going to be important for our adults versus our pediatrics. And lastly, we have this endotracheal tube, which we're going to get into so much more in another lesson. And this is used to maintain an open airway, deliver oxygen, and is essential for our mechanical ventilation. And this concludes our lesson all about oxygen delivery. I will see you in the next one.